ठीक है तो मैं खत्म किए लेके समझा वो बंद कर देती है लेके खत्म किए इसको रिकॉर्ड करने लाती है
रिकॉर्डिंग ऑन
आपको और
हाँ 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 बनार जो है ना सर बनार जो लेक्चर ऑन
45 मिनट की 30 सेकंड today's topic is bronchial asthma. Now definition. Now this is a chronic inflammatory disease in which there is hyper-responsiveness of the airways. Clinically, it presents with chest tightness, dyspnea, cough, and wheezing. It is usually it usually occurs due to bronchoconstriction, and it is constriction is variable and it is reversible. Now types. There are mainly two types, atopic and non-atopic. Atopic means when any person is able to form the immunoglobulin E to external antigen, then he is called atopic or atopy. So there is one type atopic, that means external allergens are involved in the bronchial asthma. Another type is non-atopic or intrinsic type, in which there is no any external allergen, but there is attacks of bronchial asthma. Another variant is the uh, cough variant asthma. Cough variant asthma that usually occurs in the children, especially nocturnal cough, attacks of cough without any wheezing or chest tightness or cough. So these later on, these nocturnal attacks or cough are diagnosed as a presentation of bronchial asthma. So that is a rare presentation that is difficult to diagnose because presentation is only with the cough. Now, what are the precipitating factors? Exercise, cold weather, house dust might, for example, dusting of the clothes or bed sheets, paste, these are insecticide, cockroach or fungi. It can cause allergic bronchopulmonary aspergillosis and can cause this asthma. Certain drugs can cause a bronchial asthma, for example, beta blocker, prostaglandin, aspirin, NSAID. So these are various drugs responsible for this bronchial asthma. Now diagnose, how you will diagnose this bronchial asthma? Uh, First, clinical features, as I have discussed, four features, these should be present along with forced expiratory volume in 1 second. That is increased by more than 15% after bronchodilator or steroid therapy. I am again explaining. We measure the baseline forced expiratory volume in 1 second. What is the forced expiratory volume in 1 second? After taking deep inspiration, patient is asked to exhale forcibly, and whatever the amount is exhaled in the 1st second, that is called the forced expiratory volume 1 in 1st second. So after bronchodilator therapy or steroid, it should increase by more than 15%. Hello? Hello? Slide hala. Hale bandi. Hale bandi. Wait for 1 minute. There is a problem with slide movement. So second slide, you will find slide next slide in few minutes. Second feature is post expiry volume. Post expiry volume in 1 second is decreased by more than 15%. More than 15%, there is decrease in post expiry volume in first second after taking exercise for 6 months. So we take the baseline force expiry volume and then ask the patient to exercise. After 6 month exercise, we again measure the force expiry volume in 1 second. If there is decrease from previous level more than 15%, that is also diagnostic feature. Third feature is the more than 20% diurnal variation on peak expiry flow. ये स्लाइड जो हले ही कौन दी अगते पर थे कौन ये इनमें खराबी आ जाए
नहीं क्लिक करो ना जगह देखो जगह
ओके
हाँ क्या
बस सही थैंक यू third feature is the more than 20% diurnal variation on peaks expiry flow. Diurnal means there is difference in the peaks expiry flow in the morning and the evening. So there should be difference of more than 20%. If we ask the patient to make a this diary, then you will find there that there will be more than 20% of diurnal variation for more than 3 days a week for at least 3 weeks. Other investigations increase total and allergen specific immunoglobulin E. As this is allergic disorders, so there will be total increase and as well as allergen specific increase in immunoglobulin E. Skin prick test, for example, patient is allergic to some substance, then the solution is prepared of that substance and skin prick is done. If patient develops asthma, that means patient is sensitive to that substance. Then the X-ray. X-ray usually remains normal during attack. Sometimes there may be hyperinflammation or sometimes when there is plug, this mucus plug in the bronchioles that may cause collapse of the lung or there may be allergic bronchopulmonary aspergillosis that cause shifting shadow, flitting shadow on the lungs. Next is the airway hyperresponsiveness. Airway hyperresponsiveness. We usually give any substance and then it will cause this increased airway responsiveness that will result in bronchoconstriction. We go on and usually histamine is used and we can assess the airway hyperresponsiveness. Then is the differential diagnosis. Every patient with wheeze, cough, or dyspnea is not having bronchial asthma. So there are many differential diagnoses. Most important differential diagnosis is COPD, then left ventricular failure, then upper airway obstruction, or there may be vasculitis. So upper airway obstruction, for example, foreign body infection or laryngeal edema, patients usually will present with stridor. Stridor is the inspired wheeze. So difference between stridor and wheeze is that wheeze are usually expired while stridor is inspired. And further this loop bronchoscopy or this spirometry we can diagnose this upper airway obstruction. Second is the differential diagnosis left ventricular failure. In this patient may present with cough, dyspnea and wheeze, but important feature will be bilateral basal crinkles. These are not present in bronchial asthma. Third is the COPD that usually presents in the similar way. But difference is that in bronchial asthma, patient is free from symptoms for some time. But in COPD, patient is never free from symptoms. There is relief of symptoms, but patient is never free of symptoms. And second is the reversibility. Bronchial asthma is reversible spontaneously or with drugs, while this COPD is not reversible. Reversibility is present slight but less than 15%. So reversibility less than 15% is present in the COPD. Treatment. Step one, there are many steps. So we how to give the treatment initial stage, second step, patient is not responding. The second step, they not responding. The third step, fourth step, fifth stage. That depends on the severity of bronchial asthma. For example, bronchial asthma is mild. That means attacks are less than once a week or less than 2 nights per month. Then only beta agonists are prescribed. Beta agonist means salbutamol or terbutaline. This meter dose inhaler are used. Patients should be asked to use as needed. When there is need, they can use. Second step, if patient is not condition is deteriorated, for example, when there is more than 3 attacks per week, or patient uses this beta agonist more than 3 times per week, or patient is awakened for 1 night per week, then we switch to inhaled corticosteroid. Inhaled ICS means inhaled corticosteroid. There are many preparations in the market, for example, beclomethasone, budesonide, fluticasone. These are various preparations. In third step, if patient is not responding, then we add long-acting beta agonist. In the long-acting beta agonist, salmeterol and formoterols are available. Now next, if patient is not responding, then we will increase the dose of steroid and then add new drugs. Leukotriene antagonist that is available as montelukast. Montelukast is a drug which is the leukotriene antagonist. That may help. We should try that. Then theophylline, for example, aminophylline. These can be used, or itraconazole can be used. That is the antifungal drugs if patient is having allergic bronchopulmonary aspergillosis. In step 5, final step, patient is not responding to any treatment, then final result is to start the steroid. Lowest dose 7.5 milligram daily, or what patient can afford, but it is full of side effects. It will result in the Cushing syndrome. If steroids are used for more than 3 months, then patient will develop osteoporosis, and we have to add biphosphonate to prevent this osteoporosis. And full-fledged Cushing syndrome, hypertension, Cushing phase, diabetes, peptic ulceration, skin bruising, all the features. Now, what is the acute severe asthma? This is asked in the exam during Viva. What is acute severe asthma? So, peak expiratory flow rate is between 33 to 50% predicted. That means what should be normal उसका 33 to 50% होना चाहिए. Respiratory rate is more than 25 per minute. Heart rate more than 100 per minute. Unable to speak in one breath. Patient is unable to speak in one breath. So these are the features of the severe attack. Then again, life-threatening attack. What is a life-threatening attack? When peak expiratory flow rate is less than 33%. Arterial pressure of oxygen is less than 60 millimeter mercury. Partial pressure of carbon dioxide is normal or raised. Silent chest, cyanosis, exhaustion, confusion, and coma. These are features of the life-threatening attack. Now, question is how you will treat the acute severe asthma. In what, for example, patient is admitted, how you will treat the acute severe asthma. Number one, oxygen. You will give 60% oxygen, full high concentration oxygen. Number two, bronchodilator. Usually salbutamol 5 milligram or terbutaline 2.5 milligram by nebulizer. Third step, if patient is not responding, then we have to add anticholinergic, for example, ipratropium, this 0.5 milligram. Third step is we have to add steroid. Either patient can take prednisolone 40 milligram straight, or we should start this hydrocortisone 200 milligram daily. Antibiotic is usually added because infection may be the precipitating factor of bronchial asthma. Now, indication of intubation and ventilation. This is again asked. This question again asked in the Viva. When you will intubate. If patient is not responding, means patient goes in respiratory arrest. He a coma. He is unconscious patient. Patient is exhausted, confused, or arterial partial pressure of oxygen is less than 8 kilopascal, or partial pressure of carbon dioxide is less than 6 kilopascal. Then these are indication of ventilation, intubation and ventilation, till patient recovers. The now another variants of asthma. In aspirin-induced asthma, that is another entity. It usually occurs in middle age, especially female, and having history of this allergic rhinitis and nasal polyps. In these patients, if this usually present in the middle age, in these patients, if you give aspirin, then there will be severe attack of bronchial asthma. These patients are also sensitive to the NSAID, non-steroid anti-inflammatory drugs. So, if patient is allergic to aspirin, then you should select the give the selective COX-2 inhibitor. COX-2 inhibitor selective. There are non-selective, selective. The NSAID. So you have to give selective. These will not induce the symptom. Now, if suppose lady is pregnant, she develops asthma, then how you treat? What are safe drugs in the pregnancy? All the drugs are safe. For example, this beta agonist, steroid, theophylline, but you should avoid this prostaglandin F2A because that can induce the severe attack, then can cause the severe attack of bronchial asthma. Now, bronchial asthma, that is all. Now, what are other symptoms of the respiratory? What are symptoms of respiratory system? Most important symptom of the respiratory disease are cough, dyspnea, chest pain, and hemoptysis. Now, cough. Now, what is the cough? It is the forceful exhalation against the closed glottis. During this process, a sound is produced that is called the cough. So, by listening to the types of cough, you can diagnose underlying disease. So, cough, there may be acute, subacute, or chronic. If it lasts for more than 3 weeks, that is usually labeled as chronic cough. If less than 3 weeks, it is usually acute cough. And sometimes viral infection can cause airway hyperresponsiveness, and the dry cough may persist up to 6 weeks. So there is no any danger that will subside itself. Now, extra thoracic cough, extra this pulmonary causes of cough. There are also extra pulmonary, means there is no defect in the lungs, but patient may present with cough. The most important cause is the AC inhibitor. Second is the post nasal drip, and third is the gastroesophageal reflex. Post nasal drip means usually patient is having rhinitis, sinusitis. There is continuously dribbling of this nasal secretion, and there is desire to clear the throat repeatedly, and patient may cough. But this X-ray is normal. There is no any lung disease. Gastroesophageal disease reflex can cause this cough due to this reflex of acid. When it enters the respiratory tract, it can induce the cough. Third, AC inhibitor, these can cause the dry cough. It is usually not diagnosed early, so you have to take the history of the drugs in a patient who present with a cough, persistent dry cough with normal X-ray. So history may diagnose. Second, cough. What are various types of cough? There may be wheezy cough. That means bronchial asthma or the COPD, or moisty cough. That means there are secretion, infection in the lung, or there may be bovine cough, in which this forceful, this explosive, this factor is lost. Patient also have hoarseness of voice. He cannot forcibly speak. He cannot forcibly cough. That is called the bovine cough. Most important cause is left recurrent palsy or this laryngitis. Second symptom is dyspnea. Dyspnea is important symptom in the patient admitted in the medical ward. Dyspnea can be due to respiratory disease, it can be due to cardiac disease, it can be due to metabolic disease, it can be due to anxiety. So you have to diagnose. And that is also patient can present with severe dyspnea, that is also medical emergency. So you will know in detail when you will come in the ward and take the history of patients, duration, dyspnea and exertion, orthopnea, paroxysmal nocturnal dyspnea, trypopnea, platypnea. These are various terms used. You will discuss in the ward when you will take the history. So, cardiac most important thing is that cardiac patient can present with dyspnea as well as respiratory. disease patient can present with the dyspnea. So how you will differentiate, and if a cause of dyspnea and cardiac disease, you have to take the full cardiovascular system examination, X-ray, ECG, and if cause is respiratory, again there's a respiratory function test as well as this X-ray. But even then, sometimes very difficult to diagnose dyspnea, whether the cause is respiratory or cardiac, because an old age patient may be having both disease, for example, COPD and ischemic heart disease. So, very difficult to differentiate. Uh, Next complaint is the chest pain. Uh, if chest pain is due to lung disease, that specific pattern is that it is superficial. It is knife like cutting, and it is increased by the inspiration or coughing. So, if patient complains of chest pain, ask the patient to cough or take deep inspiration. So, if pain is increased, that means a pleuritic pain. That means it is due to lung disease. Sometimes uh, patients of lung disease can present with the central chest pain. For example, mediastinitis or pulmonary embolism or tracheitis. So, central chest pain can be a manifestation of respiratory disease. Next symptom is hemoptysis. Hemoptysis means blood in the sputum. Fourth, most important cause of hemoptysis are tuberculosis, carcinoma of lung, bronchiectasis, pulmonary embolism. There are many causes, but you have to take at least these four causes. That is all for today. I-